So this is what concordance means. One point I want to make, do not accept any kind of variation. If you have to make a concordance, the first one is negative concordance, all are QS patterns. The second one is positive concordance, all are RS complexes. So you should see that all the leads have that particular morphology. Even one change we cannot accept, because that means the activation could be happening through the His-Purkinje system. So concordance we need to ensure. So it just tells us that entire activation is happening through the ectopic focus only. Any evidence of capture beat or a fusion beat? A fusion beat is nothing but ventricular focus captures a bit. The His-Purkinje system conducts through antegrade channels, so you get a mixture of ventricular as well as a normally conducted beat. So if you see this, again that suggests that it's a ventricular tachycardia. So we'll go through some examples. So this is a very classic VT, monopomorphic VT, wide QRS, more than 200 milliseconds, indeterminate axis. Then you can see the notching and also the Josephson sign is there. RS is positive, Brugada is positive, very classical VT. Again here very broad QRS complexes. You can see fusion capture beats here. So this is where you can see this is a fusion beat. These are capture beats. So sometimes the AV node, the supraventricular conduction is possible. So again we can see the Brugada sign is positive in lead V6, the R to S, the R to nadir of S. So that's where it is more than 100 milliseconds. So this is again suggestive of VT. Third example, broad QRS complex, northwest axis, and then some P waves probably you can see in the AVF. You can see some change in morphology of this. Here. So these could be the P waves. So again this could suggest a VT. Extreme axis deviation, northwest axis, QRS is positive in AVR. There is a RBBB pattern. So the left, what they mean to say, if you see RBBB pattern, the left ear if it is big, it is more suggestive of a VT. If the right ear is big, it is more suggestive of an SVT. So this is a classic VT with RBBB morphology. This is an SVT with aberrancy. Now can you make out the difference? You see the initial activation, the R wave is thin and small, the axis is inferior axis, the QRS is narrower, and the initial activation is less than 40 milliseconds. So this is a feature of an SVT with aberrancy with an LBBB morphology. This is an SVT with aberrancy with an RBBB morphology. So we can see the right rabbit ear is bigger here, narrower QRS, the axis is inferior axis. So this is SVT with aberrancy. So again some drugs which can cause wide tachycardia is tricyclic antidepressants. So with their action on sodium channels they can cause this kind of appearance. Sinus tachycardia is there. There is a first degree AV block. The P wave is hidden on the T wave, and we can see it in the leads V1 and V2. The P wave you can see it's here, it's there. And broad QRS waves, positive R wave in AVR. Antidromic tachycardia, again it's an activation of the ventricle. Unlike orthodromic tachycardia, the antegrade activation happens through the axillary pathway, retrograde through the His-Purkinje system. So you have a wider QRS, but it's a regular tachycardia as we can make out here. It's responsive to adenosine. One common ICU arrhythmia is digoxin. So this is a case, you can see the atrial rate is quite high. These are the P waves. So the P wave rate is quite high, and there we can see that they are intermittently being conducted, and there is a block also. This is a path with AV block. It's a feature of digoxin toxicity, and this is a coarse atrial fibrillation with a fixed ventricular rate. Again, this is in rheumatic cases we see they sometimes comes with bradycardia, and we find this giant fibrillatory wave. So it means that the patient is overdosing on digoxin. There is a junctional escape with a coarse atrial fibrillation. And another dreaded complication of digoxin is bidirectional VT. We can see it's a ventricular tachycardia, but see the morphology of the QRS. It's changing with each beat. Feature of digoxin toxicity. Sometimes you may see a benign bigeminy or something. These are early features of digoxin toxicity. Again, this is atrial fibrillation in a patient of WPW syndrome. You can see that the RR interval is not stable. So there is a supraventricular activation, wide QRS, RR interval is not stable. So this is an AF with WPW. Pacemaker mediated tachycardia, pacemakers with atrial sensitivity can actually sometimes pick up a VA conduction and then give rise to a tachycardia. They are made out with their pacemaker spikes. Always you may not see the pacemaker spikes. Sometimes they may be very small, but then this is a reflection of the VA conduction. The atrial lead channel will sense it as a atrial activation. Then it will stimulate the ventricle. So you need to set your PVARP settings to mitigate this. Another dreaded ECG is a polymorphic ventricular tachycardia. It's where multiple morphologies are there of the ventricular activation. When associated with a QT prolongation, it's called torsade. So here in this case, we can see that the QU, or QT is prolonged. There is a EAD is there early after depolarization that has triggered off a VT. So we had an experience with a case. This patient had presented with respiratory distress, cardiac dysfunction was there. The first ECG was on the day of presentation. On the second day, the patient developed atrial fibrillation. So instinctively, like any other person, we had started the patient on amiodarone. But then what has happened on the third day is, you can see the QT has actually got quite prolonged. And as we were seeing on the monitor itself, the patient went into a polymorphic ventricular tachycardia. So then we realized that it is the amiodarone which is actually contributing to that. And also he was also a case of stress myopathy. Then we discontinued, gave her magnesium and all. Then gradually over the next few days, the arrhythmia settled. So these are the few things I wanted to share about tachycardia.